Hello, my name's Jeremy Cullen, and I'm an intensivist from Brisbane, Australia. I'm going to be talking to you today about steroids in septic shock.
I can't figure this out. Maybe if we tried stress dose steroids. I think I'll tell Dr. Cox that. I can't figure this out. Maybe if we tried stress dose steroids.
Or maybe we just fill a syringe with false promises and inject him with that. Says here, you already got that one covered.
So, when your niche medical controversy mixed onto a major American sitcom, it is probably not so niche anymore. And certainly, the role of steroids in septic shock has been an ongoing controversy for many years in medicine. This slide just gives a brief breakdown of the major trials. Initially in the 70s, there were small trials suggesting that steroids were beneficial. But then in 1980, Roger Bone's group published this study in the New England Journal using high-dose methylprednisolone that showed, in fact, there was worse outcomes for patients with septic shock, specifically those with high creatinines. And so steroids fell out of favour. Then during the 90s, there was a renewed interest in using steroids in low doses, so-called physiological doses, although they weren't really physiological. And the rationale for this was the concept of what was called relative adrenal insufficiency, and then became renamed as CIRCI, critical illness-related corticosteroid insufficiency. This suggested that there were patients who were unable either to produce enough cortisol in response to their illness, or might have a resistance to the effect of cortisol at a tissue level. And if these patients could be identified by means of a corticotrophin test, then they might specifically respond to steroid treatment. And so in 2002, Dejali and Lan published this landmark paper that looked at patients who had been given corticotrophin tests, and those who were non-responders and got steroids seemed to have an improved mortality. And this led to a sudden uptake in the use of steroids for sepsis. However, then in 2008, Charlie Sprung and his group published the Corticus trial of the New England Journal of Medicine, which effectively attempted to replicate Anand's previous study, and they found no effect on mortality. And so this kind of left everyone in a bit of a quandary. It wasn't clear whether steroids were effective or not. Both these trials had methodological issues, so both significantly underpowered, for example. And so what we saw was a wide variation in the use of steroids for sepsis, and no one really kind of knew what to do. And by 2018, we had about 20 randomized controlled trials, most of them pretty small, about 11 systematic reviews and meta-analyses, and yet, no, the question was still unresolved. So in 2018, there were 2 new trials published, and these were by far the largest and most methodologically rigorous trials that have so far been conducted in this area. We had adrenal and APROX, and you can see the details of those trials there. Adrenal was using 200 milligrams of hydrocortisone compared to placebo, randomized, blinded control trial, and APROX was using 200 milligrams of hydrocortisone plus fludrocortisone against placebo, also, of course, a blinded randomized trial. These are the headline results. And you'll see that those of us who were hoping to have some kind of resolution to this question had our hopes cruelly crushed, because of course the results were divergent. Adrenal found no effect on mortality from steroids and sepsis, whereas APROX showed in fact there was a significant improvement in mortality amongst the patients given steroids. The other thing to note there, of course, is that the mortality in APROX for both the control and the intervention group was significantly higher than it was in adrenal. We looked at the secondary outcomes. There was a lot more similarity between these 2 trials. Both of these trials seem to suggest beneficial effects of steroids amongst the secondary outcomes. Steroids clearly led to quicker reversal of shock. There was a suggestion they might lead to earlier weaning from mechanical ventilation and earlier discharge from intensive care. So, look, this was where we were, and to be honest, it was kind of disappointing. We've been looking at this question now for over 50 years, you would have hoped we might have had an answer, but our two trials had given us divergent results on the primary outcome of mortality. So why was that? And I'd like to spend a little bit of time sort of now delving into why might it have been that these results were different.
You've got to think for yourself. You're all individual. Yes, we're about to increase quality. You're paying the time. Yes, we are all the time.
I'm not.
So, were the populations different? Well, it's clearly they were. So if you look at the inclusion criteria, we can see with Aprox here that there was a minimum dose requirement for the vasopressors, which was actually quite a high threshold they had to have, whereas in adrenal, there was no minimum dose requirement. Any dose of vasopressor was adequate as long as it was there for at least 4 hours. And you look at the things like the lactate and the percentage of patients who needed dialysis, it was clear that the Aprox patients were sicker. And that, of course, was reflected in the mortality of the placebo group between the two trials. Now, the Aprox patients had about a 20% higher mortality than those in adrenal. So they were sicker. But does that explain the difference in outcome? So there has been this suggestion in the past that steroids were more effective if you were more unwell. And this is a paper from 2009 that looked at a number of trials of steroids and compared the outcomes with the odds of death of the patient. And you can see that if the patients were more likely to die, then there seemed to be more likely to be a beneficial effect of the steroids. Whereas in those patients who were less sick, there was this trend to perhaps steroids being harmful. So that's all well and good. But the problem with it was that it doesn't really seem to be a good, plausible biological explanation of why steroids would be acting in that manner. And it just seems a bit unlikely, doesn't it? If you're really sick and you're teetering on the edge of death, then the steroids can kind of pull you back. But if you're not that sick and you're a little bit of away, then the steroids just give you a bit of a push over. Not quite clear how that would work. And when we looked into the results of adrenal in a little bit more detail, we actually don't see any evidence of it at all. So, this is a subgroup analysis. These are predefined subgroups from the adrenal trial. And I want to draw your attention to two in particular. And these are the two subgroups that are looking particularly at the patient sickness severity. So these are patients who have either high or low dose of catecholamines at randomization, and those patients with either low or high Apache 2 scores. The first thing to point out is there is no difference in outcome between these two groups, whether they get steroids or not. The other thing, though, is that the direction of the effect is opposite. So in patients who are on low doses of catecholamine, i.e. who are perhaps not as sick, here the direction of effect favours placebo, whereas in patients who have got low Apache scores, i.e. not that sick, the direction of effect is in favour of steroids. So no consistency, no signal to suggest that the patient's sickness severity influences the outcome. We also looked at a post-hoc sensitivity analysis in adrenal. So what we did was identify the patients in adrenal who would have fulfilled the inclusion criteria for Aprox in terms of the minimum dose of vasopressor required. And we looked at the outcome between those patients. And we had about 1,000 of them, as you can see. And once again, found no difference in outcome. And interestingly here, you'll notice that the mortality rate of these patients was very similar to those in the Aprox trial. So we had clearly identified patients who were that sick, but we saw no evidence of a beneficial effect of steroids in that group. So while yes, the Aprox patients were sicker, that doesn't seem to explain the difference in the outcomes that we saw. What else could it be? So, should we take fludrocortisone? So this is sort of kind of interesting. The Aprox trial used fludrocortisone, and adrenal didn't. In fact, most trials of steroid in sepsis don't use fludrocortisone, and the reason is because it's a kind of a non-controversial endocrinological fact that hydrocortisone in pharmacological doses does have a mineralocorticoid effect. You know, if someone is suffering from an adrenal crisis, for example, you just give them hydrocortisone and they get better. You don't need to give additional fludro. The hydrocortisone affects a mineralocorticoid receptor. So to explain why fludrocortisone might be having, if you like, an individual effect separate from the cortisol, we have to look into the biochemistry a bit. So here we've got a diagram of a cell, a primarily mineralocorticoid active cell, perhaps a renal tubular cell or a sweat gland or something of that nature. And you see we've got the aldosterone that circulates in the plasma. It comes down into the cell and it binds to the mineralocorticoid receptor, and that leads to mineralocorticoid action. Now there's also cortisol circulating in the plasma that also goes into the cell, and the cortisol can bind to mineralocorticoid receptors and lead to a mineralocorticoid action. But what happens is there's this enzyme, 11-beta-HSD2, and what that does, it inactivates the cortisol. It changes it to cortisone, so the cortisol cannot bind to this receptor, and the cell only responds to aldosterone. Now, when you give pharmacological doses of hydrocortisone, Addison's disease or in septic shock, because of the very significant increase in cortisol concentration, the 11-beta-HSD2 enzyme is overwhelmed, and there is lots of free cortisol in the cell still, and that binds to this receptor, and so causes a mineralocorticoid action. So theoretically, if in sepsis there is an upregulation of the 11-beta-HSD2 enzyme, that is a theoretical pathway by which the cortisol might all be inactivated, and that might leave the aldosterone, or indeed in this case the fludrocortisone, free to come and affect the mineralocorticoid receptor and have an independent action, separate to the cortisol. So that kind of gives, or leads to two questions. Does that happen? And then, what actually would potentially be the effect of fludrocortisone that could lead to reduced mortality? So, does it happen? Well, we don't have much evidence, but the evidence we have suggests that it doesn't. So this is looking from two studies, looking at kind of whole body HSD2 activity. And you can see here that patients with septic shock seem to have significantly lower HSD2 activity than controls. And this trial showing, in fact, that over time, the HSD2 activity in patients with sepsis actually falls. Now, these do have limitations. No, they're not looking at specific tissue activity, but there's also been studies looking at things like the expression of the beta-HSD2 producing gene, which doesn't seem to be increased in sepsis. So we don't really have good evidence that there is a mechanism by which the fludrocortisone could act independently, or indeed any understanding of how it will exert an effect on mortality. However, there is this trial that just actually came out last week, which is very interesting. So published in JAMA. This is a retrospective cohort study that looked at, as you can see, over 80,000 patients with septic shock, and looked at those patients who got given hydrocortisone and those that got given hydrocortisone plus fludrocortisone. And you can see that the ones that got fludrocortisone seem to do better. Now, this obviously is not a randomized trial, so we have to be cautious in what conclusions that we can draw from it. But we do now have this kind of interesting sort of situation where there doesn't appear to be a clear mechanism either how or why fludrocortisone would reduce mortality, but it is undeniable within the two trials of sepsis and steroids and septic shock that have shown a beneficial outcome are the two trials that use fludrocortisone. So this is possibly, I think, still an open question. Does the route of administration matter? Well, another point of difference between adrenal and aprox was that adrenal used an infusion of hydrocortisone rather than bolus dosing. And look, cards on the table here, the reason we did that was because it was cheaper, rather than from any kind of deep insight into the pharmacokinetics of hydrocortisone. And, is it possible that this might have been the reason for the difference? Look, it doesn't seem very likely, to be honest. This is a trial comparing glucose control and shock reversal in patients receiving either bolus or infusion doses of hydrocortisone. And you can see that the infusion leads to a better control of glucose, but no difference in shock reversal. And then we have another trial, again looking at shock reversal in patients with sepsis. And in fact, this one suggesting that the infusion was more effective in reducing shock than bolus dosing. So no real signal there to suggest that patients receiving bolus steroid are likely to do better than those receiving it as an infusion.
Where is the poison? The battle of wits has begun.
So, where was the etomidate? Etomidate is an anesthetic induction agent, but it's very hemodynamically stable, and so it's used very commonly for intubating critically ill patients. But it has this effect that it's a specific inhibitor of cortisol synthesis. So therefore, its use in a trial looking at the effect of hydrocortisone is clearly a potential confounding issue. When we look at previous trials and what they've reported about etomidate use, we can see that it has not been an exclusion criteria in 2002 or Quartibus. And there was a significant amount of etomidate use reported in those trials. Up to a third of patients received it. Its effect on the results is really not very clear. Now, etomidate is not available in Australia and New Zealand, and it was an exclusion criteria in the adrenal trials. There was a very low use of it. And in fact, we did a sensitivity analysis with those patients that received etomidate removed, and it had no effect on the results. In aprox, etomidate use was not an exclusion, but it's not clear what proportion of patients received it. So this is just a little video of me. If you go to the actual paper and you type etomidate into the search tab, you get no results. In the aprox paper and in the supplementary appendix, etomidate is completely absent. It's not mentioned at all. So it's unknown how many patients received it or in what proportions. Now, later on in correspondence about the trial, Djali did actually address this, and I'll just sort of just look at that in a bit more detail. You can see here in this letter, he says none of the patients in the aprox trial received etomidate at any time before or after randomization. So that's pretty clear, but it's still interesting as to why that wasn't in the trial. So, where has this left us? Well, it's left us, I guess, still in a bit of a quandary. It's not quite clear why these trials found different results. Some suggestions, but nothing obvious. So where do we go from here?
I don't know.
A wise choice, monsieur.
Now, how would you like it served? All mixed up together in a bucket?
Yeah, legs on top.
But of course, avec des œufs frites.
Clearly time for a meta-analysis. And sure enough, there are several meta-analyses, unsurprisingly, that were performed soon after the publication of the two large trials. And you can see the results summarized there. And effectively, the results are the same. No evidence of mortality effect from steroids. You may also be able to discern the bias of some of the authors by how they chose to frame those results, and I'll leave that up to you to decide which way that goes. But overall, no effect seen in the meta-analyses. Now, there is currently an IPDMA being performed, an individual patient data meta-analysis that is using individual patient data from both aprox and adrenal and the other major trials in this area. That hasn't been published yet, but it may have been published by the time you're seeing this. And so it would certainly be worth looking at that as well if you're interested. But at the current time, we don't have solid evidence from meta-analysis that suggests that steroids are beneficial. So this is kind of where we are with steroids in septic shock. But I do want to talk just briefly about a couple of other trials that are not septic shock as such, but that I've called sepsis adjacent. So you'll be familiar with this. This is, of course, the finding that dexamethasone in patients with COVID-19 reduces mortality. So there you can see 22.9 versus 25.7%, so a significant improvement in mortality by patients who had COVID who were given dexamethasone. But I think the interesting things to kind of look at here in the context of what we've been discussing is that this trial did find a benefit in the patients who were sicker. So patients who are mechanically ventilated, patients who are getting oxygen, they're the ones who seem to receive benefit. The other thing that's worth pointing out is that dexamethasone has no mineralocorticoid activity. So there is no fludrocortisone effect that can account for this. This is the other trial I'd just like to mention briefly. Again, came out very recently, the hydrocortisone in severe community-acquired pneumonia. This found a very substantial reduction in mortality, over a 6% absolute reduction in mortality in patients who had severe community-acquired pneumonia given hydrocortisone. And again, in relation to what we've been discussing, I think the interesting things to point out are that these mortality rates are much lower than the patients we've been talking about, the 40% in APROX, for example. So you might say they're less sick patients, but they're clearly getting benefit. Septic shock was in fact excluded from this trial, as it wasn't, patients with septic shock were excluded for enrollment, but a number of patients went on to the vasopressor requirements. And again, no fludrocortisone was given in this trial, so no fludrocortisone effect. So that's, I guess, a kind of brief summary of the state of the evidence for steroids where we are. I thought I just might talk very quickly about, where do we go in terms of further research? I think one thing, obviously, is fludrocortisone. It's not used a great deal at the moment, but, we've seen there is some suggestion that it might be beneficial. So I think there's clearly a role for further studies on that. But the other thing that I wanted to talk about is this concept of heterogeneity of treatment effect. So there's this concept that, if we have a group of patients who have septic shock and whom outwardly on clinical assessment and our current understanding all look pretty much the same and would all fit inclusion criteria for enrollment in a trial, although they may seem to be very similar, in fact they're actually very different, and they may have different genetic expressions, may have different physiological responses that mean some of them might respond beneficially to a particular treatment, such as, say, steroids. Some of them may respond poorly to that treatment, and some may have no response at all. And if you can't identify these subgroups, then it may not be surprising that you get divergent and strange results from your trials, because you may have different proportions of these patients in your groups, and you have no way of knowing. So if we could somehow identify these patients, identify subgroups that might respond differently to, in this case, for example, steroids, then we might have a better way of targeting that treatment. So do we have evidence that this is occurring? And in fact, yeah, we do. So this is from the Vanish trial. And this is a sort of a retrospective analysis. And what they did here was they identified patients who had two different patterns of gene expression, SRS1 and SRS2. And when they went back and, so this is not randomized, but when they went back and looked at those patients who'd got either hydrocortisone or placebo, they found in the SRS1 group, this didn't seem to make a difference to their outcome. But in the SRS2 group, this different pattern of gene expression, these patients seemed to do worse when they got given steroid. We did some work on this from the adrenal patients, and we looked at a panel of genes that are related to corticosteroid metabolism and physiology. And again, we found something sort of similar. We found that in the group of patients that had an increased expression of this particular gene, HSD1, then those patients with high levels of expression resolved their shock faster than those with low levels. And an opposite effect with this gene, the patients with high expression of GLCC1 actually had slower resolution of shock than those patients that didn't. So there is some suggestion that, if we could perhaps identify patients that maybe have different responses to steroid, and this may not be just by genetic expression, it might be, for example, cytokine expression. There is some evidence, again, that some particular patterns of cytokine expression may indicate patients who are more or less responsive to steroids. So if there's some way that we can identify them more accurately, then maybe we might be able to use steroids in a particular subgroup of these patients and see good results. So I thought for my final slide, I'd just talk about what I do. And look, this is in no way intended to be didactic. You guys have now seen the evidence and you can make up your own minds, but this is kind of where I am with the use of steroids and sepsis in the moment. So take from it what you will. As I said, I think the evidence that they improve mortality is not clear, but there does seem to be reasonable evidence that they improve outcomes that patients would care about. So patients probably don't really care if they come off noradrenaline faster, but things like coming off the ventilator faster, leaving ICU faster, I think that is beneficial. And so for that reason, I think it's useful to use steroids, and I do now give them to patients with sepsis in that standard dose. I don't use a threshold dose for vasopressors, so anyone on vasopressors, and I don't do it by whether or not the patient is more or less sick. I give them for 7 days and then stop, no tapering. And I tend to give boluses because it's easier, but I don't think it matters either way. We haven't spoken much about this concept of corticotrophin test, but I think most people now are coming to the conclusion that it is not necessary. We did actually look at whether or not patients' baseline cortisol level would indicate whether or not they were responsive to steroids, and found that it doesn't. And there's really no point measuring the cortisol level. It won't tell you whether people will respond to steroid or not. So I don't think there's any requirement to perform a corticotrophin test. And as of now, I am not giving fludrocortisone, but who knows? Maybe that might change in the future. So thank you very much for your attention. I hope you found the talk useful. Like to be done. Thank you.